a 65-year-old female presents with chronic lower back pain and fatigue. I am showing you coronal T1, sagittal T1, and sagittal T2 magnetic resonance images of the spine and pelvis. Please describe the findings.
The T1 magnetic resonance images demonstrate patchy, variegated areas of intermediate to low signal intensity throughout the marrow of the lumbar spine, pelvis, and proximal femurs. The sagittal spine magnetic resonance images confirm similar variegated abnormalities throughout the lower thoracic and lumbar marrow.
What is your primary diagnostic concern?
The findings of a patchy, variegated pattern of marrow infiltration in an older adult are highly concerning for multiple myeloma, though diffuse osteolytic metastases can look identical.
What is the cell of origin for multiple myeloma, and what is its status as a primary bone malignancy?
Multiple myeloma is a neoplastic proliferation of monoclonal plasma cells. It is the most common primary malignant tumor of bone overall.
What are the 4 classic magnetic resonance imaging marrow infiltration patterns described in multiple myeloma, and which has the poorest prognosis?
The 4 patterns are normal marrow, focal geographic lesions, patchy or variegated foci, and diffuse infiltration. The diffuse infiltration pattern is associated with the poorest prognosis.
Why is a classic radionuclide bone scan frequently negative or falsely normal in patients with multiple myeloma?
A bone scan is often negative because multiple myeloma stimulates osteoclast activity without inciting an osteoblastic bone response. Bone scans require osteoblastic activity to show tracer uptake.
What is the preferred radiographic screening modality, now recommended over the classic plain film skeletal survey?
Whole-body low-dose computed tomography is now the preferred screening modality. It has a significantly higher sensitivity for detecting early lytic bone lesions than the traditional plain film skeletal survey.
What laboratory workup is required to confirm the diagnosis of multiple myeloma?
The diagnosis requires serum and urine protein electrophoresis to identify a monoclonal M protein spike, along with free light chain assays and a bone marrow biopsy.
Finally, what are your clinical management recommendations?
I recommend urgent referral to hematology-oncology for systemic therapy, which may include chemotherapy, immunomodulatory agents, and autologous stem cell transplantation. Bisphosphonate therapy is also indicated to reduce pathologic fractures.